Hello friends and welcome back to Gastro Guru. My name is Dr. Nisak Patel. I am a gastroenterologist from SIDS Hospital, Surat, Gujarat. Today we'll discuss a few live interesting cases of vomiting. So aim of these videos are for the medical students, the residents as well as the practicing doctors so that they can get a better insight in the subject of gastroenterology and these videos can help you in your day-to-day practice. So please stay tuned. For any comments or any video if you want me to make, please write in the comment section.
गैस्ट्रो गुरु के साथ बढ़ाएं अपने पाचन स्वास्थ्य का अनुभव, जहां विज्ञान और वास्तविक ज्ञान मिलते हैं। ऑथेंटिक मेडिकल हेल्थ इंफॉर्मेशन, गैस्ट्रो गुरु के संग।
So previously in the first 3 videos, what we have discussed is how to approach a patient with vomiting, discussing the pathophysiology, how to take better clinical history, how to investigate such cases, what drugs to use. So these 4 things has been covered in the last 3 videos. If you have not seen those videos, kindly refer back to it because there are major practical insights in these videos. So coming back to the first case, so a 31-year-old male software engineer who is residing in Canada, Indian origin. He has come to India for a vacation, and as soon as he landed, he has a 1 month history of total vomiting. So 1 month history, we must take it either as chronic vomiting or episodic vomiting, as we discussed in the previous videos. So the vomiting per day is 7 times per day and with preceding nausea. So it is not a projectile kind of vomiting. And obviously ask whether there is food present there or not. Also ask for the associated symptoms like fever, weight loss, etc. So he has just a non-specific abdominal kind of pain. Negative history, we need to obviously rule out any central causes. So there is no history of headache, diplopia, ataxia, ear discharge, ear pain, etc. So there are no history of such things. I specifically asked for any history of drugs, but he denied. So investigations initially, the CBC, LFT, RFT, CRP, etc. was normal, except there was hypokalemia because of profuse vomiting. The sonography and X-ray abdomen was normal. There were 2 or 3 sonography done within the span of 1 month, and one of the sonography mentioned that there is mild enteritis. We come across many of such reports, but always take a clinical context. If the CBC, CRP is normal, the patient is not having fever, then don't consider this as infection. He was treated by an MD physician in a nearby place as acute gastritis with Pantocid infusion, some antibiotics because of the enteritis, and given IV fluids and other symptomatic treatment like perinom, MSET, etc. And with this treatment he got better. So this is the first admission that he had. However, as soon as he was discharged, the symptoms again reappeared after 5 days. Again the same investigations were done, but it was normal. Plus now a CT abdomen was done to rule out any other GI problem because there was a non-specific abdominal pain. However, it was normal, and almost again he was given a similar kind of treatment, and there was no pinpoint diagnosis, and he got better with the symptomatic treatment and again discharged. So now the question is that what is the diagnosis in this case and how to approach. We come across these cases very commonly, and the dilemma is how to approach these cases. Now again the symptoms reappeared in 2 days. So now the catchy point here is either we must give this history as chronic or episodic. So I would classify this patient as episodic because there are asymptomatic periods in between. So a period of 5 days, again a period of 2 days, and it is getting progressively worse. He started having headache. He was not able to sleep. There was anxiety, palpitation because he was here to enjoy his vacation in India, and he was just running from pillar to post from one doctor to another without any diagnosis and was not getting relief. Now when he was referred to a gastroenterologist and endoscopy was done which showed gastritis. But mind you, gastritis without any reason and presenting in this manner is not the case. So don't dismiss this case as gastritis. Now even MRI brain was done because of the headaches, which was again normal. He consulted two gastrophysicians in this span of time without a diagnosis. There were further treatment added, like beta blocker, considering that this might be a vertiginous migraine. For anxiety, he was given benzodiazepines. PPI was changed. So many a time, what we see, if we change from pantoprazole to rabeprazole, the patient might get better for gastritis, but this was not the case. He was not getting better, and he was given all possible antiemetics, even the centrally acting ones, but he was not getting better. So the family was very disturbed, the patient was very disturbed. He was referred to me for actually the third opinion, because he has already consulted two gastroenterologists. So my diagnosis was, this is a episodic vomiting. So as we see here, so in these, the things in the red, they are episodic vomiting. So it can be either a functional vomiting, it can be some eating disorders, it can be cyclical vomiting, it can be migraine, it can be cannabis related problem, it can be labyrinthitis, BPPV, it can be starvation ketosis, hormone based treatment. So I have taken every history in detail, but the patient did not come up with a positive history. So my working diagnosis was episodic vomiting. There was a very one classical history which the father of the patient gave to me, that he has a history of repeated warm water bath, and the patient was here in the month of June. So in the summers he was taking warm baths almost 5 to 6 times a day. So his father said कि सर वो बहुत, उसको पहले शिवरिंग होती है, उसको ठंडी लगने लगती है, उसके सारे जो बाल है वो खड़े हो जाते हैं, और फिर गर्म पानी में वो नहाने चला जाता है. जैसे ही वो गर्म पानी से नहाता है, फिर उसको 2-3 घंटे के लिए अच्छा लगता है, और ऐसा वो 4-5-6 बार ऐसा गर्म पानी से नहाया करता है. दिस इज़ अ वेरी क्लासिकल पॉइंट इन द हिस्ट्री विच विल सी लेटर, एंड दिस पॉइंट एक्चुअली क्लिंच द डायग्नोसिस फॉर मी. And the funny story behind this is that patient was hiding one very crucial history. I already asked this patient one history in previous my consultation, but he did not give me that history. I indirectly conveyed my message कि भाई मुझे पता है कि what is your problem, and I give him few hints, and I could see it in his eyes. So he recognized कि भाई ये डॉक्टर को अब पता चल गया है. So this is the doctor who can save me from this. But because he was afraid of his father, he was not giving me that history. So the quiz question is that what question did I ask? So I asked him whether he was taking any weed or not. So the diagnosis in this case is cannabis hyperemesis syndrome. So he was in Canada, where cannabis is very easily available. He was a software engineer, a learned guy. His father in Surat is a diamond worker, and with very hardships he was sent to Canada. So he was afraid of telling this to his father that he was taking drugs. So by which mechanisms cannabis causes vomiting, they are still not very well elucidated. It acts on CB1, that is cannabinoid 1 receptors. It can be because of both. Usually it is because of overuse of cannabis, but because he was coming to India, there was no access to cannabis, and he was having vomiting just because of the withdrawal effects of C1b receptors. The warm water bath that he was having is because the cannabis is also cannabinoids which are present in our body. They also helps in thermoregulation. So because the thermostat is disturbed, the patient will have repeated attacks of chills, which will get better with taking hot water baths. It also increases the level of dopamine. So some of the cases get better with domperidone temporarily. So that was the reason that he was getting better with perinom and domperidone in between. But because you are not giving specific drugs for CB1, the patient was having recurrent episodes. The treatment for such cases is, number one, the patient needs to be under de-addiction. Haloperidol, that is Serenase, is one drug which can abort these attacks, and we need to give some prophylaxis centrally acting agents like amitriptyline, and we need to give him domperidone or metoclopramide for a prolonged period. So for around 1 month he needs to be on these drugs. So coming back to case 2, so a 14-year-old boy with chronic vomiting, there was no nausea. It occurred immediately after meals. So in the previous 3 videos what we have seen कि अगर खाने के तुरंत बाद vomiting होती है, so उसका मतलब the problem can be in the throat, the problem can be in the esophagus. So जैसे ही खाना जाता है, if there is achalasia or a tumor, so there will be immediate post meals vomiting. Other reasons, it can be either hormonal or psychological. So any pregnancy patient, they will have immediate post meal vomiting. Some drugs, it can cause immediate post meal vomiting. Some central problem, it may be a functional problem or organic problem, it can have immediate post meals vomiting. There was food present in the vomiting, and the classical thing was effortless. Now the patient will not give this history, you need to ask them. So what I ask is कि बेटा आपको vomiting कब हो रहा है. So the parents tell के सर जैसे ही वो खाना खाने बैठता है, थोड़ा 3-4 चीज़ें खाता है, फिर तुरंत उठ के वो अपने बेसिन में या वॉशरूम में जाके वॉमिटिंग कर देता है. सो आई आस्क्ड देम कि उसके पहले तुम्हें जी मचलता है वगैरह कुछ होता है. उसने बोला नहीं. मैंने बोला तो होता क्या है. तो ऐसे ही वो खाते खाते मुंह में खाना आ जाता है एंड वो बाहर जाके थूक देता है. तो दिस इज एफर्टलेस. सो वी हैव ऑल अंडरवेंट एन एपिसोड ऑफ वॉमिटिंग. वी ऑल नो हाउ बैड इट इज़. सो जब भी हमें वॉमिटिंग लगता है उसके पहले पूरा जी मचलना, थकान, कमजोरी, पसीना पसीना होना, ऐसा लगेगा अभी होगी एंड देन वी हैव वॉमिटिंग. But in this patient, the patient is just eating, अचानक मुंह में आया, he will just go to the bathroom and washroom and he will just vomit it out. So this is a classical case of effortless vomiting. CNS symptoms were normal. Investigation was done elsewhere. The blood investigation, ultrasound, CT, abdomen, endoscopy, MRI brain, everything was normal. He was treated with multiple drugs, but the drugs were not effective. So the problem in any case is that if we don't have a good diagnosis, we cannot treat these patients well. So the just symptomatic treatment won't work. Now this was affecting his education. The family was very disturbed because a 14-year-old boy having vomiting since very long. So what was my impression? The impression is chronic vomiting because it was happening almost daily. There was no asymptomatic episodes and without nausea. So what you must do as physicians or as students, just give a syndromic diagnosis. Don't pinpoint the diagnosis at one point. So you need to see whether it is acute, chronic or episodic. So now this case is a chronic because it is continuing for more than 2 weeks and without any major breaks. Whether there is nausea or not, so that is very important. And the important point here is effortless. So now we need to differentiate between effortless vomiting versus a projectile vomiting. So projectile vomiting में क्या होगा कि पेशेंट को एकदम एक्चुअली जोर से उल्टी होगी without nausea. While in effortless vomiting, the food will just come up. So it is type of a reflux kind of symptom. So in the first video, we saw the difference between nausea, retching, vomiting and reflux. So these are the 4 symptoms which can be, the patient will give history in a similar manner. We need to dissect the different causes. So I took some history in detail because the causes is that the patient was not having dysphagia, so esophagus is ruled out. All metabolic and hormonal profile was worked up. So thyroid, calcium, sodium, potassium, these all were normal. Acetone was normal, sugar was normal. So then we were I was thinking that there is some central problem, but MRI brain was normal. So the only thing which was left was functional. So many of these patients will have some or other functional problems. So for children, you need to ask कि उनके स्कूल में क्या चल रहा है, ट्यूशन में क्या चल रहा है. तो the history that they gave was कि अभी स्कूल चेंज किया है 3-4 महीने से. ट्यूशन में he was not very good at his studies, so his tuition teacher was rebuking him. There were some interpersonal problems in the family. उसका एक छोटा भाई था जो अभी born हुआ था 2 साल. So the younger brother was getting more attention from the family, so he developed some attention seeking behavior problems as well. So diagnosis in this case was a rumination syndrome. So what happens in rumination is that is repetitive regurgitation of the food. Mind you, this is not vomiting. So this may be re-swallowed or expelled. So there will be reflux. जैसे कि गाय को होता है कि what cow does is it chews the food, it swallows, then it will come up again. The cow will chew and again it will swallow. It will fasten the process of digestion. So it is a learned behavior. Especially this happens in infants and children, and this is usually a response to any distressing episode. So whether there is any psychological or distressing or stressors factors, like in such this case, बच्चे की स्कूल चेंज हुई थी, ट्यूशन में उसको डांट पड़ रही थी, फैमिली में उसको अटेंशन नहीं मिल रहा था, तो बिकॉज टू डेवलप so that the family members give due attention to him, he has developed this behavior. So जैसे ही खाना खाएगा, बाहर आएगा, तो मम्मी पापा उस पर ज़्यादा ध्यान देंगे. So that is how the pathophysiology of rumination syndrome works. It may be present in adults if there are major stressors, anxiety or any psychological conditions. We see it quite often कि जब बच्चे को हॉस्टल में आप भेज देते हो, तो वहाँ पे उल्टियाँ कर करके वापस आएगा. It is quite often present after pregnancy or after a new marriage. So many females may we have seen, after new marriage, if the patient is coming up with a similar history, the diagnosis can be a rumination syndrome. Diagnosis is clinical. The Rome criteria suggests that effortless and recurrent regurgitation of the food within 30 minutes of eating. So खाना ऊपर आएगा within 10, 15, 30 minutes, और जब वो खट्टा हो जाएगा, दिस स्टॉप्स. सो पेशेंट को अगर आप पूछोगे तो पेशेंट विल गिव अ हिस्ट्री कि जो वॉमिटिंग आ रहा है उसमें क्या आ रहा है, स्वाद क्या है. वो बोलेगा सर जो मैं खा रहा हूँ वैसे ही स्वाद आ रहा है. पर अगर वो खट्टा हो जाता है उसके बाद इट स्टॉप्स. इट इज़ मोर कॉमन एट होम. सो व्हेन यू आर सराउंडेड विद द पीपल बाय यू नो, दिस बिहेवियर विल बी मोर कॉमन. सो ऑलवेज हैज द हिस्ट्री कि भाई ये जो उल्टियाँ हो रही है, अगर आप कहीं होटल में खाने गए या कहीं मैरिज फंक्शन में गए तो वहाँ पे होता है, तो आंसर विल बी यूजुअली नो. देर आर टेस्ट, मैनोमेट्री विद इम्पेडेंस स्टडीज कैन हेल्प यू टू डायग्नोज दिस केसेस, बट इफ यू टेक अ वेरी गुड क्लिनिकल हिस्ट्री देन द डायग्नोसिस इज वेरी इजीली मेड. Treatment of choice is baclofen, but it works in only 50% of the patients. The main thing is psychoeducation. You need to explain the family. So आपको बच्चे को अलग से समझाना पड़ेगा, फैमिली को अलग से समझाना पड़ेगा. फैमिली को क्या समझाना है, तो don't give a due attention to this. And बच्चे को you just to be ask him to be rest assured. These patients are not doing it deliberately, so you cannot scold this patient कि तुम नाटक कर रहे हो etc. This language is not acceptable. You need to explain कि हाँ बेटा ये problem है. For this boy, because he was a 14-year-old boy, I just drew some cartoons कि यहाँ पे brain होता है, यहाँ पे पेट होता है, दोनों के बीच एक connection है, और जब भी फिर आपको वहाँ से नसों का खिंचाव होता है तो आपको vomiting हो जाता है. So in such cases we can explain in a similar manner. If there is underlying depression, we are not the good judge. We can take help of psychiatrists and we can treat it very effectively. फैमिली को क्या आपको समझाना है कि भाई ये अगेन रीअश्योर्ड देम एज पेरेंट्स, बिकॉज पेरेंट्स को ज़्यादा चिंता लगी रहेगी. उनको बोलो कि ये कोई चिंता वाली बात नहीं है. आस्क देम टू रीड दिस ऑन गूगल. कि आप चाहो तो रुमिनेशन को आप वहाँ पे गूगल पे जाके पढ़ सकते हो और उसमें आपको बेसिक इन्फॉर्मेशन मिल सकती है, और इस तरह से ये होता है. ज़्यादा ध्यान दोगे तो ये बढ़ेगा. सो इन दिस आई आस्क देम कि कोई भी इंटरपर्सनल इशू है, सिबलिंग राइवलरी, सिबलिंग पे ज़्यादा ध्यान नहीं दो. डायफ्रामेटिक ब्रीदिंग ऑल्सो हेल्प्स. सो दैट्स ऑल फॉर टुडे. Thank you for watching this video. Stay tuned for more. In the coming up, we have a few more cases we'll discuss in the next video. Thank you.
गैस्ट्रो गुरु के साथ बढ़ाएं अपने पाचन स्वास्थ्य का अनुभव, जहां विज्ञान और वास्तविक ज्ञान मिलते हैं. ऑथेंटिक मेडिकल हेल्थ इंफॉर्मेशन. गैस्ट्रो गुरु के संग